When we will finish this lecture, you should able to know what is the normal cellular content, what is the intracellular accumulation, which occurs due to fatty changes, due to protein metabolism changes, due to carbohydrate changes, due to pigment involvement, and pathological changes due to intracellular accumulation. Intracellular accumulation. We define this accumulation of abnormal amount of various substance due to manifestation of metabolic derangement in the cell. The normal cellular constituent is the lipids, protein, glycogen, and carbohydrate. And inside the cell, when these carbon, silicon, asbestos, or bacteria enters, these are the abnormal or exogenous constituents that enter and accumulate inside the cell, and they alter their normal cellular function. What are the mechanisms that causes the accumulation of these intracellular accumulation? Due to sometimes due to overproduction, due to inadequate metabolism, lack of enzyme machinery to remove any abnormal constituents that enter inside the cell. Again, the normal cellular constituent, as we talked about, water, lipid, and carbohydrate, and abnormal substance like we talk exogenous, like mineral, product of infectious agent, endogenous, like product of abnormal synthesis or metabolism. These abnormal constituents either get inside the cytoplasm or sometimes they get enter into the nucleus. So the sources of these are produced by the affected cell, produced elsewhere in the body but stored in the cells. Now talk about the process of accumulation. So we talk about the four major process. Number one, the production of normal endogenous substance and normal or increased rate, but the rate of metabolism is inadequate to remove it. So production of normal endogenous substance at normal or increased rate, but the rate of metabolism is inadequate to remove it. Like fatty liver, in which reabsorption protein droplet in tubule of the kidney. So this is a abnormal metabolism. So these fat get deposited inside the cell. Second, accumulation of an abnormal endogenous substance, product of mutated gene due to defect in protein folding, transport, inability to degrade abnormal protein efficiently. Example, accumulation of mutated protein in liver cells. So a defect in protein folding transport, so accumulation of abnormal protein inside the cell. Number three, accumulation of normal endogenous substance due to inherited defect in enzyme required for metabolism of substance like lipid and glycogen storage disease, in which there is a lack of enzyme, so that cause lysosome storage inside the cell. So we call that a lysosome storage disease. And the fourth one, that is indigestible material, carbon or heme. So this ingestion of indigestible material inside the cell accumulated and they alter the cellular function. Intracellular accumulation, manifestation of metabolic derangement by either they may be transient and reversible or permanent. So when there is any accumulation inside the cell, it become permanent. So its effect ranges from either it is harmless to toxic. We classify this intracellular accumulation into three categories. Accumulation of constituent of normal cell metabolism like fats, protein, and carbohydrate. Accumulation of abnormal substance of abnormal cell metabolism like that usually occur in storage disease, inborn error metabolism, or the accumulation of pigments. And pigment can be further classified endogenous pigment or the and exogenous pigment. Accumulation of lipids. When we talk about the accumulation of lipid, then we are talking about the triglyceride, cholesterol, ester, and phospholipid. Ketosis or the fatty changes, there is an abnormal accumulation of triglyceride within the parenchymal cells. So mostly this lipid get deposited in liver, may also deposit in heart, skeletal muscle, kidney, and even other organs. Causes of this fatty liver or accumulation of fat in the liver is the alcohol abuse, those people who are alcoholic, those who are suffering from diabetes, obesity, protein malnutrition, those who are taking certain drugs or toxin, suffering from anorexia, and especially in female having a pregnancy. So this is a chart showing the how these free fatty acids get enter and oxidize and they get out from the liver cells. So free fatty acid get enter in the liver cells and to turn into fatty acids. They free fatty acids, fatty acid turns into triglyceride. Triglyceride is converted into lipoprotein and they come out. So enhanced fatty acid synthesis by the hepatocyte is usually occur due to this or impaired lipoprotein excretion. If defect in any of steps uptake or catabolism or secretion can lead to lipid accumulation in the liver that we call as a fatty liver. Defect in any of step that we have mentioned here, free fatty acid into fatty acid, then triglyceride, then turn to the lipoprotein, and there is any problem in this, then that liver, this fatty acid again accumulate in the liver that we call as a fatty liver. So see, this is the gross picture of the liver that look like greasy type appearance of fatty liver. So a fatty liver is an enlarged and has a greasy pale yellow look. See, in above picture that showing the normal liver and how it look like diagrammatically on microscope. Below picture that is showing a brownish type picture of the liver and that we call it the fatty liver and how these fat vacuoles are seen on the microscope. I will show few histopathological diagram of this accumulation. So on the light microscopy, small fat vacuoles in the cytoplasm around the nucleus, so small fat vacuole can be seen. And if this not reverse, then at the later stage, the vacuole coalesces to create clear space that displays the nucleus to the cell periphery. Occasionally, contagious cell rupture or fatty cysts. So this is the picture that you are seeing over here, in which there are fatty vacuoles that are seen multiple. So this is a slide of fatty liver, but the architecture of the liver is still not disturbed. That you are seeing a triad. Again, another picture of the fatty liver, and in which you are seeing fatty vacuoles. Again, another picture of the fatty liver in which you are seeing a portal tract, biliary duct, this venules. This is the triad of the liver that is intact, and you are seeing multiple vacuoles, fat vacuoles in the liver, and you are seeing a nuclei in the hepatocytes. Again, another slide in which you are seeing huge fatty, so many fatty vacuoles uh, in the liver. This means the liver is highly fatty. Again, another slide that's showing fatty vacuoles. Another slide that you can see, imagine the fatty vacuoles that are seen. So these are different stents that we use to see the fat in the fat, where the fat get deposited. Special stents are Sudan 3, Sudan 4, oil red, osmic red, Sudan black, and nail blue sulfates. So what is the diagram in which that is seen that of these stents, this Sudan black and oil red. When we are talking about the fatty chain, if we talk about the heart, you will find alternation of yellowish streak, that is a fatty changes occur due to the fat deposition in the heart, and reddish streak that we see in the cardiac muscle that are unaffected myocardium. So that we call the trugoid or tabby cat appearance in the cardiac muscles where the fat get deposited. Fatty changes, if there is a mild, it has no effect on the cellular function. When it is deposited more in the cells, then it can impair the cellular function. Other lipid accumulation, when if we talk about, then we should talk about the cholesterol and cholesterol stress and cholesterol. Those people who are suffering from hyperlipidemia or having a high cholesterol level, they are more prone to developing atherosclerosis. This is the deposition of cholesterol inside the vessels, so accumulate in the smooth muscles and macrophage in the intima of the artery. So in a hereditary hyperlipemia, cholesterol accumulate in macrophage, usually under the skin, forming tumor-like skin. So known as xanthoma. So in hereditary hyperlipemia, this cholesterol get accumulated under the skin and forming a xanthoma. So in next slide, I will show you the diagram how the xanthoma. Accumulation of cholesterol and cholesterol ester conditions. That is atherosclerosis. In atherosclerotic plaque, smooth muscle cells and macrophage within intimal layer of the aorta or large arteries are filled with lipid vacuoles, most of which are made up of cholesterol and cholesterol esters that have a foamy appearance. That's why we call it as a foam cell. Produce a yellow cholesterol-laden atheroma that we call as a atheromatic plaque. See, normally this is a normal cut section of the artery, and whenever there is a tear in the artery of the wall due to this cholesterol deposition, so this fatty material is deposited in the vessel wall, creating a very narrow lumen. So whenever if there is any problem occur in the blood get uh, 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 any clot formation, so it can block the vessels. So again, this picture is showing a cut section of the artery in which this is a atheromatous plaque formation of foam cells, in which you are seeing a fat deposit, macrophage foam cells, and cholesterol deposit, making this the tunica intima. Uh, so again, these vessels in which there is a huge deposition of cholesterol forming a atheromatic plaque, making a narrow lumen of the vessel. This is the foam cells that you are seeing in which there are macrophage, lipid cells, and all. Xanthoma formed by cluster of foamy cells found in the subepithelial connective tissue of the skin and in the tendon that already we have discussed. Cholesterolosis. What is the cholesterolosis? This is a focal accumulation of cholesterol-laden macrophage in the lamina propria of the gallbladder. That diagram I will show in the later slide. And Niemann-Pick disease type C, this is also called a lysosomal storage disease, caused by mutation affecting an enzyme involved in cholesterol trafficking. So one of the enzymes that help in cholesterol metabolism, resulting in cholesterol accumulation in multiple organs. This is the picture that accumulation of the fat in the epidermis. That is a xanthoma showing lipid accumulation in the dermis, above the diagram, and in the above eyebrow. So knobby appearance clue that the patient may have defect in the lipid metabolism. So again, this is the diagram of the gallbladders where this get deposit, cholesterol deposit. So this is called cholesterolosis, in which the accumulation of lipid in the gallbladder submucosa may be an indicator of the other disease. Ciliated epithelium that is shooting upward that get distorted over there. Intracellular accumulation of protein. So when we are talking about the intracellular accumulation of protein that usually occur due to by these three ways: excess exceeding capacity of cell to metabolize, synthesis secretion of excessive protein, defect in protein folding, rendering them vulnerable to intracellular aggregation. So, nephrotic defined by 24 urine protein more than 3.5 per grams. So, in nephrotic syndrome, more than 3.5 gram protein comes in the urine by the 24. So, manifested as cytoplasm protein droplet in renal tubular epithelium. So, this is manifested as a protein gets deposited in the renal tubular as a cytoplasm droplet. When we talk about the synthesis and secretion of excessive protein, so monoclonal immunoglobulin in serum or urine due to bone marrow containing excess number of neoplastic plasma cells. So whenever this is the neoplasm of the plasma cell which secrete a lot of immunoglobulin that usually occur in a multiple myeloma. Third, inherited metabolic disease plays resulting in less than 10% normal plasma level of alpha 1 antitrypsin with accumulation of protein in hepatocytes. So, these are the three ways in which the protein get deposited in different cells. Intracellular accumulation of protein primarily in the epithelial cell of the proximal convoluted tubule of the kidney and in the plasma cell. In the kidney, this excessive accumulation occurs subsequent to leakage of protein from glomeruli into the glomerular filtrate that we call as the Russell bodies, alpha 1 antitrypsin deficiency, and Valery body or alcohol honey in the liver. So accumulation of protein appear as a round eosinophilic droplet vacuoles or aggregate in cytoplasm. So this get deposited in the cytoplasm. On electron microscopy, they can be amorphous, fibrillar, or crystalline in appearance. This is the diagram where protein reabsorption droplet in renal tubular epithelium that are seen. Again, protein accumulation that are seen in the glomerular of the kidney. So here in this picture, excessive normal protein that we call as a Russell bodies that we are seeing, and secondly we are seeing a normal plasma cells. Again, due to excess protein, we are seeing plasma cells and as well the Russell bodies. Modes of protein accumulation, reabsorption droplet in proximal renal are seen in renal disease associated protein loss in urine, that proteinuria in with heavy protein leakage across the glomerular filtrate. So there will increase reabsorption protein into vesicle and protein appear as a pink hyaline droplet within the cytoplasm of the tubular cells. Second way, the protein accumulation may be normal, secreted that protein are produced in excessive amount as occur in certain plasma engaged in active synthesis of immunoglobulin that we already talked about in the myeloma. So endoplasmic reticulum become hugely distended, produce large homogeneous eosinophilic inclusion called Russell body that I show you in the last two histopathologic pictures. So third way, defect intracellular transport and secretion of critical protein. Usually this happens in those people who are suffering from alpha-1 antitrypsin deficiency. So four, the accumulation of cytoskeletal protein in the example in the microtubule, actin filament, myosin filament, intermediate filament, keratin filament, neurofilament, desmin filament, vermetin filament, and glial filament. So the accumulation of this. And number fifth, aggregation of abnormal protein usually occur in metabolic disorder like amyloidosis, where proteinopathy or protein aggregation disease happen. So here, this is a picture of the liver where there is an aggregation of abnormal protein that are you've seen that we call amyloid in liver. So accumulation of amyloid protein outside the cell corresponding the nearby hepatocyte and impaired their function. So they impair the function by accumulation in the liver. Intracellular accumulation of glycogen. Glycogen infiltration and glycogen appear as a clear vacuole in the cytoplasm of cells that usually occur in hyperglycemia. Epithelial cells of the distal portion of the proximal coronary tubule and in the loop of Henle in the kidney. Here, that glycogen can accumulate. Leukocyte with inflamed or necrotic tissue, even in the liver or in the cardiac muscle fiber. Not last but not least, that intracellular accumulation of pigments. As in start, I told you, pigments of type. One is a exogenous, other is a endogenous. So pigment which are colored substance of which are normal concentration, example melanin, whereas other are abnormal and accumulated under special circumstances. That we call as the endogenous. So exogenous pigment like carbon and in which the coal in the coal dust, in which a disease that we fall called anthracosis or coal worker pneumoconiosis, tattooing, those people who do the tattoos, the different tattoos on the skin, ingested certain lead, carotene, silver, etc. And these pigments get enter into the different cells. Exogenous, when we talk about endogenous, that is the lipofuscin, melanin, and the hemosiderin. So pigments are two type, exogenous and endogenous. Exogenous carbon, tattooing, and ingested. And when we talk about the endogenous, there is lipofuscin, melanin, and hemosiderin. Exogenous pigment like carbon that cause a disease would call anthracosis, coal dust that cause a disease pneumoconiosis, a lung pickup alveolar macrophage, and the regional lymph node blackening the tissue of the lung that we call the anthracosis. So those people who are working in coal mines and other, they inhale these carbon particles these carbon particles get interested into the alveolar where they take macrophage and involve the regional lymph nodes and making a blackening of the tissue and person suffer from anthracosis. Again, the slide that you are seeing, the black streak seen in between lobules of the lung beneath the pleural surface are due to the accumulation of anthracoid pigment. Here is the anthracoid pigment in macrophage in the hilar lymph node. This is the slide of the lymph node below the right. Again, a slide, exogenous pigment of anthracoid pigment in the lung, in the alveolar space, in the alveolar septum, the coal dust particle and silica fragment injures the lung tissue and causes it to scar. Carbon material which may be associated with coal dust or car exhaust are too heavy to be exhaled and are deposited within those scars. Hyaline changes refer to the alteration within cell or in the extracellular space that gives a homogeneous and glassy pink appearance in the routine histology section stand with Hematology E. Reabsorption droplet, Russell body, alkaline, hyalinization of the wall of the renal arteriole in long-standing hypertension and diabetes mellitus. So another pigment that we call as the lipofuscin. This is an insoluble pigment, also known as lipochrome or wear and tear pigment, composed of polymer of lipid and phospholipid in a complex with protein. This is not injurious to the cell or its function, telltale sign of free radical injury and lipid peroxidation that usually occur. In section, it appears as a yellow, brown, finely granular cytoplasm, often perinuclear pigment, seen in liver and heart of aging patient. Patient with severe malnutrition and those who are suffering from cancer cachexia, we find this lipofuscin in their cells. Again, that is this yellowish pigment that we are seeing here in the cardiac muscle, that is a lipofuscin. So again, this is a more high power view in which you are seeing in the lipofuscin in the cardiac muscle. Again, lipofuscin that we are seeing in the liver, that is in the hepatocyte. Again, the lipofuscin that we are seeing in the cardiac muscles, in the liver cell. Again, in the cardiac muscle. Now we have to talk about the melanin. Endogenous non-hemoglobin derived brown black pigment. Only endogenous brown black pigment formed when the enzyme tyrosinase catalyzes the oxidation of tyrosine to hydroxyphenyl in melanocyte and dendritic cell. So disorders the melanin pigmentation, either it may be hyperpigmentation or the hyperpigmentation. So in hyperpigmentation, Peter syndrome, melanosis coli, and nevoid tumor that is seen on the lips and below the eyelid. Hypopigmentation, just like a vitiligo, a white baby, and due to the low melanin in the skin. Now we have talked about the hemosiderate, another pigment, important pigment that is derived from the hemoglobin is a golden yellow to brown granular or crystalline pigment, a major storage form of iron. Hemosiderin pigment represent aggregate of ferritin cells. Small amount of hemosiderin can be seen in the mononuclear phagocyte of the bone marrow, spleen, and liver, which are actively engaged in the red cell breakdown. If we talk about the excess of iron, systematic acquired hemosiderosis usually occur in the hemolytic anemia, those people who are getting a repeated blood transfusion, are sometimes giving more iron to the person that we call iatrogenic. Heredity, that we call a disease hemochromatosis, in which either there is an increased absorption and excessive dietary intake. This is a picture of the liver where this iron gets deposited. So this is a slide of the hemochromatosis. So iron pigment appear as a coarse golden granular pigment lying within the cell cytoplasm in the liver. So to properly see the iron store in the cells, we do the Persian uh, blue stance. So here the Persian blue colors give the iron. So endogenous pigment in the liver where you are seeing iron. So same tissue section, different stains. So these two slides having a same tissue but different stains. So with time, these hemosiderosis deposit will impair hepatic function and leads to cirrhosis. Now see, only the iron deposition or excessive iron deposition in the liver that can lead to the cirrhosis. Again, these are the Persian blue stain in which we are seeing different iron section. So the brown coarsely ground material in macrophage in the annulus is hemosiderin that accumulate as a result of breakdown of RBC and release of iron in the heme. The macrophage clear up this debris which eventually recycled.